Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us for our program today, The Cost of Health Literacy. If you have a question about anything being discussed today, please call or email us during our broadcast. The phone number and the email address are on your screen now and will appear later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You'll need to register for the program in order to access the material. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credits will only be awarded for 1 year for nurses, expiring on September 30th, 2018, and 2 years for social workers, expiring on September 30th, 2019. Now let's meet our presenter. Dr. Joy Dupree is the Executive Nurse Fellow at the Robert Wood Johnson Foundation and Assistant Professor and Director of Community Engagement at the University of Alabama, Birmingham. Dr. Dupree?
Thank you, Ashley, and thank you to the AHEC groups as well as the Alabama Department of Public Health Distance Learning and Telehealth Division for allowing me this opportunity to come to you today to discuss a subject that is very close to my heart, which is health literacy. So we will get started. Our objectives today are to really describe patient populations at risk for low health literacy, to identify barriers and solutions that influence health literacy for diverse patient populations, and then have you recall some of the evidence-based practices for culturally and linguistically appropriate patient and provider communication. This will by no means encompass all of these topics today because it is very difficult to cover the vast knowledge and experience that is out there from all the folks that have been studying this for about 20 years. But we'll touch on some of these topics and hopefully some of the resources and references during the presentation as well as at the end will provide you with some contacts that you can further your education in this area. So if you look at health literacy and when the initiative began in America to really focus on this, it goes back to the 1990s. And I love to present this first bullet point because it's the World Health Organization concept of health literacy that so many times when I talk to providers, they discuss that they understand health literacy and that that's patient education. And it is, but it is a much, much broader topic than that. And so health literacy goes beyond a narrow concept of just health education and individual behavior-oriented communication, but it also has to include and address the environmental, political, and social factors that we now call the determinants of health. And then in 2000, you'll see that the Health and Human Services defined health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. This definition is but one of about 35 different organizations worldwide that have defined health literacy, but this sums it up, and many of them are very similar. So we talk about health literacy, and one of the things that in research we always look toward is how do we know what we know? Why is this important? Why is it worth putting resources toward solving a problem? And so beginning in 1992, there was a national assessment of adult literacy. And it was known as the National Assessment of Literacy Survey, the first time in 1992 that it was administered. And I could probably spend 8 hours talking to you about this one study, but to be brief today, I want to tell you a little bit about some of the findings from that study and to tell you that there was a follow-up study 10 years later in the United States, and there were very few changes. And so we had not really made any improvement, significant improvement. And there was another study internationally 10 years after that was not favorable toward the United States. It did not show that we were making any progress. And so this is something we need to closely evaluate from our educational standpoint as well as our provider and healthcare standpoint. So if you look at this slide, how do we know what we don't know? And those different surveys, this is a compilation of some of the information from those surveys. And if you look at the chart, if you start at the top in the green slide, the green pie, if you will, it is 12% of our population falls into the proficient category of understanding and being able to act on health literacy information, basic health information. That's you and I, most likely, folks that have had experience with the healthcare system or have had lifelong illnesses and understand how to navigate the healthcare system. It doesn't, health literacy does not always equate to literacy, but it's very closely correlated. And so even folks that are in the proficient category, if you put them in a stressful situation in a hospital with an unexpected admission, they may also have considerable challenges because the anxiety levels are so high. And we know that when anxiety levels are high, that it's very hard to learn. And so we can talk more about that later in the presentation. If you look at the next two pieces of the pie, the red and orange, those are the below basic and basic categories. And your indigent care patients as well as Medicaid often will fall into one or two of those categories, and sometimes into some of the other categories as well, of course. And so that makes up, the below basic is about 14%. And what does that mean? That means that they are functionally illiterate. They read at or below a 5th grade reading level. They have difficulty navigating the forms that we give them. They have difficulty understanding very much about numeracy, so that there are many challenges when they do medication, when they try to manage their medication. And then the next category is basic, and that's 22%, which those two combined give you a significant number. In the largest portion of the pie are the intermediate. That's the good news, is that we've got a large part of our population that under the right circumstances, given the right type of learning environment as well as the time from the provider to really work with them or their navigators or their community workers that we have so many of now, they really can impact these patients tremendously by answering their questions, because it's about building trust as well when we begin that relationship for provider-patient communication. And I'll bring your attention to the numbers in the parentheses. Those are the quantitative findings, meaning those were the findings related to numeracy, and they very closely mirror what the general overall literacy was, but you can see that there's so many, that we have many challenges in our nation. So disparities of at-risk populations associated with low health literacy, we know the obvious. We know that the poor and underserved obviously have a tremendous challenge. Members of cultural and ethnic minorities also have many challenges because they don't always understand, and we may not understand they don't understand. And so it's about making sure that they have the proper information in their own language and that is culturally sensitive to them. Obviously, recent refugees and immigrants and non-native speakers of English are part of this category. And the southern and western region of the United States are disproportionately larger populations with low health literacy, and obviously those with less than a high school degree. But if you look at demographically, the largest proportion of those that are affected by low health literacy are those that are 65 years and older. By 2030, our census recognizes that close to a fourth of all the United States adults will be in this category. We've seen the graying tsunami of our baby boomers that has just flooded the healthcare system related to this population. And I believe the last statistic I saw was that every day in America, 9,000 people turn 65 years and older every single day. So that's significant. And so the Health and Human Services, they've come out with several reports, but in 2007, Howard Koh at HHS wrote a report that was very, very profound that I encourage you all to read, and the reference is at the end of this presentation. And they called it out. They said 9 out of 10 American adults have difficulty with health information, so that includes a lot of folks that fall into the proficient category. So we've talked a little bit about what these folks, what categories they come from, and we've talked a lot about the aging. And so I'd like to show you this clip and challenge you to think about, depending on what generation you are within at this point, think about your parents, your grandparents, or even your peers that trust providers so much that they literally will do whatever they are told to do, sometimes totally misunderstanding. And then think about medications. We've all encountered medications that have been filled more than once that they don't look the same the second time around because of generic prescription filling. And so sometimes they don't even know what they're taking, whether it's Dilantin or Dilaudid, so we take for granted as providers that they understand those nuances, and they don't.
Well, I'm a kidney transplant. I've had the transplant for about 15 and a half years, but I've been sick forever. Okay, well, I take baby aspirin, that's something new. Cyclosporin, prednisone.
And when I make the doctor's appointments, I have to be sure that it doesn't interfere with his doctor's appointments, my doctor's appointments, or their doctor's appointment.
So you don't like to go to the hospital where they give you a lot of papers to fill out?
Paperwork to fill out.
Paperwork?
Yes.
Why is that?
Because I can't read that good.
Because you can't read that well. What does it feel like when somebody hands you a lot of paperwork and you can't read?
I feel like you're in another country.
Vitamin D, Nexium, Norvasc, Colestid, Estratest.
When you enter a doctor's office, the first thing, and you're a first-time patient there, they're going to give you a clipboard. Sometimes that is very discouraging for a patient who cannot read.
Lipitor, Paxil, Darvocet, Vitamin E.
If I'm really embarrassed or confused or worried about things around me, or worried about my child being all upset, I would not be able to read things I normally would read every day.
You know, some of the words that the angiogram, plasty, and all of that, what is that, several things or one thing, or it's just a language that I'm not familiar with.
If the patient was transferred to that facility and to any and all insurance companies or other third parties paying or obligated to pay, this is not making any sense.
Tums, Tegretol, Tenormin, sodium bicarb, Cardera.
Do you have any idea what a normal blood pressure is?
No.
Any idea?
No. It's normal?
No, it's not normal. It's high. Have you or anyone ever had to sign a consent form?
Yes. I have hereby, I don't know.
Okay, authorized.
Miacalcin spray, Nystatin, Aricept, Lasix, Ambien, Imodium when you need it, and vitamin D. I believe that's it.
Do any of those look familiar? When we think about the patients that you witnessed in this clip, you have to imagine all of these are actual patient encounters. And the lady that began the clip and the lady that ended the clip was the same one, and you saw the series of all the different medications she is taking on a daily basis, and she's a renal transplant patient. And so when you think about the challenges she must have, it's unbelievable. Ms. Tillman, the mother that is caring for her young children, who has difficulty understanding written information, also has challenges with numeracy, and we know that for patient populations in the pediatric category, this can be very, very dangerous. So as we think about this encounter they had, it was very stress-free. It was in a very comfortable environment. Think about putting them in an emergency situation in the hospital and no preparation, and you can imagine how the information that is coming to them in these encounters is just fuzzy a lot of times. So we have to be mindful of helping them de-stress before we begin to try to teach them. So I like to give this information to talk a little bit more about the South, since we are broadcasting this to the southeastern region as well as other parts. I think it's important for us to understand how different some of our states are and how well they are understanding some of the health information we're providing to them. Alabama falls in the category with some of the greatest challenges, and if you look at Mississippi and Louisiana, they rank just slightly greater in challenge than Alabama does. And this is I love this slide because a picture is worth 1,000 words, and when you look at Mississippi and Louisiana, they stand out, but then all around them, the Southeast is really challenged. And the upper Midwest has much better patient understanding. They were one of the earliest regions of the nation to begin some of the efforts for health literacy. Some of their health literacy centers and their initiatives go back close to 30 years, and so that's very exciting. So let's revisit general literacy in Alabama. And all of you can look this up on the website to find out about your state. But in Alabama, almost 500,000 folks lack basic literacy skills, meaning they cannot read. 25% lack a high school degree, and that's from the most recent information that I have. And up to almost 60% suffer from low health literacy. So we have to assume everyone we come in contact with needs additional information. We cannot judge a book by its cover. Low literacy rates by county, and this is literacy, general literacy, just as the previous slide was. The percentage of adults with level 1 literacy, meaning they read at or below 5th grade level, which we just discussed in the previous slide. This gives you a little bit more image, and it's really the area of the state that we've seen have many of the challenges related to health care as well as poverty and disparities of all types. And so it should come to no surprise that these are some of the same counties that have some of the lowest literacy rates. So we have to do a better job. We have to do more for these citizens. Health outcomes in Alabama, we have a lot of room for improvement. Small initiatives statewide can provide so much opportunity for us to begin to incrementally improve the health literacy across the state. 45 out of 50 overall health comes, 47 out of 50 for avoidable hospital use and cost, 48 out of 50 for diabetes, 49 out of 50 for cardiovascular deaths, and 49 out of 50 for infant mortality. Our previous health officer, Dr. Don Williamson, I always enjoy hearing his presentations, and he talks about the health of a state can really be reviewed in line with their infant mortality rate. And so I know there are some initiatives that have just begun in the Jefferson County area related to improving mortality rates. And I know many people across the state are working on trying to improve infant mortality. So we've got a lot of opportunity ahead of us, and this is a great time to be involved in that group because there's some funding associated with that. And if you're interested and want more information on that, call me at UAB and I'll be happy to give you the contact names of those folks. So in plain language, low health literacy contributes to basic misunderstanding, routine for patient discharge. I can't tell you how many times I've witnessed folks go in to do discharge teaching, regardless of what level of provider, and I have been a patient, and I have done this as a nurse, and I have witnessed where folks will give out the information, the patient education information, and I assume that the patient education material is written at a level that all patients can read it, but in analysis we have found indeed they are not many times. And hand it to the patient, say, I'll be back in just a minute, I want you to read this, and I want to answer any questions you have when I come back. And come back in, patient says, well, I have no questions, I'm ready to go home, and you're like, great, so you understand everything? Yes, no questions. And so, you know, I am guilty. I was one of the nurses that did that for a very long time until I learned more about health literacy. And now there's, and I'm not doing patient care right now, I'm not engaged in that part of clinical nursing. But before I left that part of my career, I was very keen to always say, tell me what it says on the paper. Tell me how you're going to do this, and let's talk through this. Because that's the true essence of Teach Back. And we lose sight because of the massive amount of work that has to be done, particularly in hospitals. Our nurses are stretched to the limit. They're doing more than ever with limited resources. And so it's hard to build in that time. I will tell you, most nurses and other providers that get accustomed to a routine on how to do proper Teach Back say it actually saves them time in the long run. And in the previous slide we talked about the avoidable hospital use and cost, and that's very closely tied to readmissions. And if we don't do a really good job with our discharge teaching, particularly with some of the chronic comorbid conditions with our patients, you'll see those folks come back in before that 30-day time frame, which is costing us so much money. That's why I love the thought of being in Alabama and using the tagline, this is not rocket science, but it's costing us that much, because if you look at some of the penalties that some of our hospitals are facing from readmissions that are really sooner than they should be, it's enormous. We can do better, and I know that we will, given some of these best practices. It contributes to poor health outcomes that lead to those hospital readmissions, and it leads to a lot of mistakes, especially with medication. Approximately 28% of all hospitalizations of older patients are attributed to polypharmacy and adverse drug events, yielding so much unnecessary cost. Excess hospitalizations and less than 30-day readmissions and unnecessary deaths. I believe our next slide will go into a little bit more detail with Ms. Tillman, who was a mother of small children managing pediatric doses, and I want you to pay attention to her encounter and think about if you've ever been a part of trying to teach a mother or patient to care for her children, as well as some of the others, because they're folks that when we encounter them in the clinic environment, they're dressed nice, they speak nice, they answer and they nod and they act like they know exactly what we're talking about, and we assume they do, but many times they don't.
You come out of that room, that examination room, with this intelligent woman or man thinking, God, I hope I don't make a mistake with my medicine, because I did not understand anything he or she said to me.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5, a tablespoon and a half.
So you give her a tablespoon and a half. Can you find where it tells you how many you take? The dosage?
Three a day?
Take 3 to 2 milliliters. And something I want to point out, I don't actually read this because I know what it says now. So if I had to sound it out, if it wasn't for I knew it, because I've heard it so many times, I would not be able to read that.
Okay.
Every 3 to 4 hours as needed for pain.
Okay. What's a milliliter?
I don't know.
The medication that was given to her was not explained. Well, we didn't use it.
In fact, she ran out of her high blood pressure medicine, so she didn't take it. She didn't call me to tell me to fill it. So finally I found out that she had not been taking it. I said, Mother, you can't do that. You have to keep taking that high blood pressure medicine.
When you get your prescription, you get all this stuff and just throw it away because my eyes are not that good.
And then it says discontinue.
Yes.
What does that mean?
I don't know.
How many times do you take these thyroid pills?
Once a day.
Okay. Do you take one of each of these?
Mm-hmm.
Okay, so you take 2 thyroid pills.
No, I take one. I more likely got them messed up when I got refilled.
And then, are these stickers helpful?
Nope, don't even look at them.
Don't even look at them.
Okay. What do you take that medicine for?
I don't know what it's for.
Okay.
He just puts me on stuff and he tells me when I have it. I just take it.
The patient encounters you just witnessed reinforce what we talked about earlier in the presentation, and one of the slides, or several of the slides, show what would appear to be non-compliance for providers. We often hear providers say to one another how they really can't deal with patients any longer that are non-compliant, and oftentimes these patients do not understand what they are supposed to do. It is not that they don't want to get better, it's not that they enjoy being readmitted, and we have to go that extra step to sit down with them and make sure that they understand what they are supposed to do, and that there is an avenue for them to reach out to you if they don't understand. So you've seen the cost related to the human factor. Let's talk a little bit about the economic impact in the United States. Limited health literacy adds between $106 billion to $238 billion annually to an unnecessary cost per year to an already overburdened healthcare system, and this is nationwide. This study was actually done about 10 years ago, but many believe that the cost is even higher now. And so you'll probably see some more data about that soon. Some of the states are working on initiatives to demonstrate what their costs are so that they can seek funding to begin to create initiatives in the hospital and community to make a difference. So I'd like to draw your attention to this slide because Arkansas took the formula that was used in the slide that provided information from Vernon about the larger United States related to the unnecessary cost, and they used the same formula and determined about 4 or 5 years ago what the cost was in Arkansas. And so I think Arkansas is probably a snapshot of most every southern state. I think Alabama may have greater challenges than Arkansas. But if you look at the cost per year of unnecessary health care cost, and this is related to hospital readmissions, unnecessary admissions, medication that wasn't used properly where patients ended up in the ER, just on, and these add up. It is amazing what we are spending in unnecessary cost. So if you're interested in that formula, there's information on how to find out how you can work with an economist or someone in your state to determine that cost. And several years ago, in 2004, as the health literacy movement was really kicking off, and some of the founders of the Health Literacy Initiative for America, Rima Rudd, Ruth Parker, Terry Davis, Michael Wolf, I could name about 15 folks that were very, very instrumental working to determine a vision for a health literate America. What would that look like? And at the time, it was the Institute of Medicine Roundtable on Health Literacy. Now we know that that organization is the National Academies of Science. But you can Google Health Literacy Roundtable, and it will still take you to all this information. And it is a very, very useful website. There are a tremendous number of very solid research reports that give you the information you need to make a case to your organization for why you need to do more in this area. But I'd like to go through quickly the bullet points of what they see as a vision for Health Literate America. And the first few are not specific to the healthcare system. Everyone should have the opportunity to use reliable, understandable information to make great health choices. That's just sort of general. That falls under the category of pretty much the general population. So we should all have that opportunity, just like we have the rights to understand what our rights are in the hospital. Health content would be basic curriculum for K through 12. What does that mean? Well, we know that many of the science classes from K through 12 have a lot of information about basic science, but can we enhance that and make it specific to health science in some of those modules that the students receive? There are several states that are making great strides in this area, and I'll show you later in the presentation where you can find that information. But, you know, there's so much that can be done, so if we can better prepare those folks as they're coming through high school, as well as junior high and even K through 5, we can begin to build on a foundation that will allow them to learn more as their knowledge base continues to grow as they become consumers. Accountability for all health literacy policies and practices. And many people will say, well, what are those policies and practices? Well, they're not always easy to find. If you look within some of the curriculum for our healthcare providers, some of that information is available through some of the curriculum that our healthcare providers are taught. But we could strengthen that tremendously. And the Joint Commission has got a lot of information out there on health literacy policies, as well as the American Hospital Association, and all the hospitals in Alabama generally have some policies related to that, as well as our public health system. And so this is more specific to health care. Public health alerts should be presented in plain language. What does that mean? Instead of saying cardiovascular, we could use the word heart. Or instead of saying neurological, you know, think of terms that are simple, that is one or two syllable terms to describe anything that you want to describe to not just patients, but to anyone that you're sending out a public health alert to. Consider cultural factors. So I think what I wanted to do at this point was to bring in those things that we as healthcare providers have to go that extra step to make sure we are doing this. And there is a classification called CLASS, and it's the Cultural and Linguistic Appropriate Standards. And you can find all of that information on the internet. And these are factors integrated into all aspects of patient materials. And it's hard. It's not always easy because we have such a diverse population now. We have to be mindful, and when we don't understand, we need to bring in folks that can help us work with populations of diversity. Healthcare practitioners should communicate with each other using everyday language. I know when I teach undergraduate students, we talk about how when they go home that first semester after they've been in nursing school, every person in their family during the holidays will approach them with some ailment to say what, because they assume they're the expert now. And oftentimes students of nursing as well as medicine, dentistry, or any of the other professions will begin to develop a wonderful vocabulary using very scientific words. And we love to use those words when we are young professionals because we think that it just is so exciting to be empowered with having that knowledge. But be mindful of who you're speaking with and make sure that they understand. We don't have to use that language, and we need to communicate with each other in a way that we can really understand each other. You've seen the cartoons where you had bubble heads where someone thought, you'll say, yes, I'm going to, and they're like, where is he going to, and so is it T-W-O, T-O, or T-O-O? So think about to make sure they understand, and there again, that goes back to our patient understanding of using TeachBack. Provide ample time for discussions with patients and healthcare providers to make sure that you have time for that discussion, and oftentimes during discharge teaching that is not the case. Patients should feel comfortable to ask questions as part of the healing process, and oftentimes we don't make them feel that comfortable. When I've worked with some groups with our hospital association and many of the folks that have gone through some of the workshops that we've conducted to help with health literacy practices, our navigators are some of our richest resources for sharing with us what patients say and how they feel. And patients often feel more comfortable speaking with them than they do a nurse or a physician because they spend so much time with them. They build that trust. So we've got to make sure we have time. Our rights and responsibilities for healthcare instructions in plain language, that's just what we have to make sure our patients are getting. So how do we know that? I encourage everyone that is handing out patient education materials to do an analysis and make sure that it is written at a grade appropriate level. It should be between 6th and 8th grade for all patient populations to be able to understand it. You would be shocked if you knew how high some of the grade levels are on some of our patient education materials. And the challenge is that often we are purchasing these materials from companies associated with either electronic medical records or agencies that we assume have vetted all of the material to make sure it's written appropriately. And I will say in the last 10 years, my colleagues that have worked on these, worked in these areas for policy change have made a huge difference. We have seen a tremendous improvement in the grade level being lowered, but many of them are still written at much too high a grade level, as well as patient consent forms. And that partially goes back to some of the legal terminology, but we have to do a better job to make sure our patients understand what they're signing. So I'd like to bring your attention now to this slide, because health literacy activities by state in America, this doesn't represent everyone, but it's a pretty comprehensive glance at what states in the nation are having an impact in their state through coordinated health literacy activities and organizations. Missouri and Wisconsin were two of the early states that have done a tremendous amount of work, and colleagues there share with me wonderful stories about the progress they're making. And California is not highlighted in this area, but the Institute for Healthcare Advancement with Michael Villar and Gloria Meyer has done tremendous work in this area, particularly with developing low-level education materials that are in booklet form on various topics. So I encourage you to look on their website because it does have a tremendous amount of information that should be helpful to most any agency. Georgia has a great initiative going that they began a few years ago. Irene Feinberg over there is doing a great job along with some of her colleagues. And you can see that all around us we have states, and then you notice Tennessee. It is not highlighted, but Dr. Russell Rothman is one of the pioneers in this area, and he really has developed an entire network in the Vanderbilt University system to help with health literacy, to make sure that they are doing a lot of evidence-based research to improve upon not only health literacy but primarily health outcomes through health literacy initiatives. Wisconsin is in the process of developing a new drug label that they are piloting, that instead of saying take as needed or take as directed or take two pills or whatever some of our prescriptions say, that will have a different label that may say take one pill in the morning, take one pill at night, or have it much clearer for the patient so that there's a much more understanding from what they should do with that medication. Terry Davis and Michael Wolf piloted some of the studies that were done early on in this area and worked with California to get legislation passed so that they could actually create a new labeling system in California. And if you want to find out the progress of that work, you can go on their website for their pharmacy organizations out there. It's been wonderful to watch them grow and overcome some of their barriers. And so this is a very wonderful website through the Center of Disease Control and Prevention that if you hover over any of these states with your cursor, you will be able to click on that state that is highlighted and find out what they're doing. And I just can't say enough good things about this website. Cynthia Bauer, who was with the Center of Disease Control and now is working in Maryland, with some of the health literacy organizations there, helped develop this entire website, and she was one of the early pioneers in this area. Online resources through the CDC also include training for health literacy in plain language. Cultural and communication is essential for anyone working with health information services, and those can be found through the CLASS website, Culturally and Linguistically Appropriate Services. Some of the other modules that the CDC offers talk about numbers and explaining risk. Online training is part of health literacy training that is available to the public as well as professionals, and there is a introductory module that's about an hour long, a little bit more than an hour, that does offer continuing ed at no charge for professionals that are interested. And I encourage every school of nursing, every medical school, every hospital, as well as any community resource center that is dealing with any related health information with the consumers in their area to at least complete that module. It is free to the public. Other online resources I've talked about are the culturally and linguistically appropriate standards. They give you 15 action steps intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally sensitive documents and services. So this is just another clip from the CDC website, and it gives you the different modules below that are available if you want to find training. Some of the modules after Module 1 are a little more specific to what your area of interest may be, but I think there's something for everyone here if you have an interest in health literacy. This is a wonderful website. We talked about how we are trying to do a better job with making sure our patient education materials are written appropriately so that patients understand them, as well as can take them home and show them to their families so that everyone understands. And Simply Put is a great little tool that was developed by some of the pioneers in this field, and it is titled appropriately with Simply Put, and I appreciate the ADPH for putting the link on here so that you can access that. You can also Google Simply Put tool and it will come up. And so I've taught a health literacy module, a course actually, for the last 18 years at University of Alabama in Birmingham School of Nursing, and it's been a campus-wide course, and one of the assignments is for students to seek out a patient education material that's currently being used and recreate it, if you will, as well as analyze it for how it is presented at this point. So this was a document one of my students presented, and if you do the readability analysis, you can see that it falls within all the appropriate categories. It's written at a grade reading ease with Flesch Kincaid reading ease at 62.7, and anything above 60 is acceptable, and the higher the better. And if you look at the grade level, it's written at a 5.2 grade level. And this is analysis of the words, but it goes deeper than that. It's much deeper on what we need to do to make sure our general public is understanding what we're trying to tell them. And so when you look at this, you think just off the bat, well, how can I make that better? And we know that we could improve it by enlarging the font. We could also be more concise. We could add color. I'm not sure if the audience can see this slide very well, but this is for asthma. And the font is so small it's hard to read, but it's very boring. But if you look at this one that she recreated, it had all the same information, but it was in a way that she could understand it and not panic. I've often encouraged patients to take these types of documents home and laminate them, put them on their kitchen refrigerator, or just put a plastic sleeve around it where it doesn't change, it doesn't get wet, and they can make sure that it stays colorful, and they can use it to just have a compass on a daily basis of what they need to know so that they don't panic, especially parents of small children, because even healthcare providers, if it's your child, when they start getting sick or having an asthma attack or running a fever, all of that information you may have learned can go right out the window. And this is just a great little tool to use. This is another website. I encourage anyone who is interested in having initiatives, particularly in research and or in their healthcare environment, to look at, because there's lots and lots of resources. There's hundreds, as a matter of fact, on this website for academia as well as providers and agencies to use if they're thinking about initiating any kind of quality improvement related to health literacy. So what types of tools are on there? A lot of the tools you'll find on that Toolshed website are associated with how to determine the level of health literacy of a patient. Some of the ones listed are the Rapid Estimate of Adult Literacy in Medicine. And it really gauges the prose, the readability. There's no numeracy. The Test of Functional Health Literacy for Adults, the TOEFL, it's no longer recommended to be used by those who developed it, but there are several others that are available that you can find in this toolshed that are related to other languages and dentistry. The TOEFL was one of those landmark tools that was used a lot during early days of research to determine really how bad our literacy levels were, and those that developed it feel like we don't need to continue to test how many people are affected by low health literacy, we need to approach it with universal precautions and assume everyone has a challenge and treat everyone the same using TeachBack. Then there's the newest vital sign that has 6 questions. It uses a nutrition label. It's heavy with numeracy, but some patients will tell you they find it intimidating because they have to calculate, and that makes them very nervous. So I don't always recommend that. Depends on the environment. And then the brief health literacy screening tool is one that I've personally had experience with using recently with one of our hospital systems that is determining whether or not they want to implement this within their clinic agencies. We don't recommend testing for health literacy broadly, but for those states that still have a question mark as to whether or not, well, do we really have patient populations that really have challenges? Some of the states that have used different assessments are Florida. Recently had a research study led by a nurse who tested and worked with their hospital admissions using the realm, I believe, so that they could earmark those that were at risk and those that were not. And when they did that, they learned a lot more of their patients had challenges than they thought. We're using this at UAB right now in a clinic environment to determine what levels of health literacy our patients have so that we can earmark it for determination, do we want to do this throughout our clinic environment? And why would that be helpful? Well, it would allow us to have the ability for all providers immediately to know if this person has more difficulty understanding. Doesn't mean we don't still go that extra step and do TeachBack with everyone, but it gives us just a quick idea of who may have greater challenges. And so the brief literacy screening tool has 4 questions. They're very non-threatening. How often do you have someone help you read hospital materials? And if people are truthful with these questions, most people will say, sometimes I do. How often do you have problems learning about your medical conditions because of difficulty understanding the written information? Question number 3 is, how often do you have a problem understanding what is told to you about your medical condition? And the last one is, how confident are you filling out medical forms? This is a slide of the findings from a feasibility pilot study that was conducted by the University of Alabama at Birmingham Gerontology Scholars Group, and it just really gives us a great snapshot of what some of our challenges are, what patients feel they're having difficulty with. And I am not able to read all of this to you because I can't see it as well as I should, but I'll tell you the findings are pretty similar with what we have found nationwide related to the patient population. We understand that there's probably about 12% that are very proficient, and many of the others have challenges. And it just gives us an idea of how to target those individuals for additional patient education. So how do we improve patient family-centered care? To get started, you could do in a clinic environment the quick assessment, and then I truly believe once providers realize how many of their population have challenges, that's when we'll see the momentum with resources put behind some of these efforts so that we can get providers better training and provide resources to allocate more time in working with some of these more challenging patients. Again, evaluate all your patient education materials to make sure they're written at the appropriate grade level as well as being culturally sensitive. And provide professional development for all employees through those CDC modules. Schools of nursing are teaching TeachBack in their curriculum, and they have some communication modules. But it's it varies how much emphasis is put on that. So possibly through simulation labs, we could begin to incorporate best practices for health literacy and make that part of our patient encounters, particularly with those schools that are using simulation, because it's such an easy way to incorporate it and learn and become second nature. I know when I was training to be a nurse practitioner, the assessment, the overall assessment was something that I found very daunting and challenging, but you get into a rhythm, and it's no different with adding health literacy best practices as part of that assessment. You begin to pick up on telltale signs of patients that may have challenges. And then advanced work, I encourage every one of you to look online for the 10 attributes of a health literate organization and really take a close look at your own organization to find out if you meet the standards, and very few in America at this point do. So this is a website snapshot of that information for the 10 attributes of a health literate organization, and the folks that developed this are the most esteemed researchers in the field of health literacy, and you will learn a lot just by reading the information on this assessment. So I love to end, as a women's health nurse practitioner, I love to end my slides with this is a communication era, because we know when women go for their annual checkup, they have different tests. And this slide says someone from the gynecologist called, meaning gynecologist, and they said that your Pabst beer was normal, and I didn't even know you liked beer. And so what I did block out were the sticky notes that said, don't let a man write a comment or take a message. So I think men are very much capable of doing this, and I think that we have to approach this, that all providers need to learn this information so that they can not only be the best they can be, but we can have a healthier population. Thank you all so much for your time and attention today, and I'm happy to entertain any questions you may have.
All right. This is a great opportunity for you to call or email with any questions right now. The email address and the number are on your screen, so go ahead and give us a call or shoot us an email. We do have a few questions here in the room, so we'll go ahead and get started with those questions.
Dr. Dupree, can you tell us, during a visit with a patient, what are some of the signs of limited health literacy that a health professional should pick up on?
That is a great question. One of the most obvious signs is when a patient doesn't complete a form completely. Many times our front staff will put the information in a computer, and providers may or may not see those original forms. So there's a disconnect to begin with. Training the front staff of any agency that does intake with patients can be one of the smartest things an agency can do. Other telltale signs are some of the obvious that I didn't bring my reading glasses. That may or may not be true, but that's a common notation in the literature about identifying folks. When they are in an environment, again, that's stressful, sometimes you'll see them asking obvious questions when some of the information is posted right in front of them. You don't know if that's related to anxiety or if it is related to that they really can't read. And so the other component is their numbers. Numeracy is such an important part of health literacy. And if you look at the way that they sometimes will answer information on those forms, if they've misspelled words, if calculations are not correct related to either birthdays or anything numeracy, those are real big red flags. But just, there's so many, but those are some of the highest ranking ones.
How do you address issues of health literacy with a patient who might not want to admit that they have an issue with health literacy in the first place?
That is an excellent question. And in the Vision for a Health Literate America, I believe one of the bullets discussed how we have to provide an environment to make folks feel comfortable sharing information and to give them the proper time to do that. We find ourselves in a healthcare system that is more rushed and resource-driven than ever, with fewer and fewer resources available to us. So the challenge becomes, how do you develop a rapport with a patient as a provider or a frontline staff and make them feel like they're the most important person when you're trying to get everybody in 12 to 15 minutes. And that's really impossible to do. And so our navigators have become one of the greatest assets that we have related to this quest to develop a rapport with patients and learn more about them. But everyone has to do their part. One of the chapters in some of the work I use are Mayer and Valari's book for healthcare clinicians. It's a very good introduction book, and it talks about creating environments to encourage patients to speak with you. And it's hard to do. You have to think about how you would feel. And there's no easy answer, but I can tell you the more time you can spend with them at a slower pace. One of the clips you'll find about health literacy and online with videos is very interesting, because we've all fallen victim as providers and probably as patients too, going in and working with providers that are new to the EMR process, that have a computer in front of them or a tablet or a laptop, and they're talking to the patient the whole time while they're doing this. And I mean, you can just see the look on the patient's face, like, I'm over here, and oftentimes there's encounters of patients that report providers on using the team-based approach, which is absolutely what we want to do, but they'll go into a patient's hospital room and they're all talking to each other over the patient, and they're not engaging the patient. They're not asking, well, what do you think? How do you feel? And we often give patients information about, you need to take one in the morning and one at night. Well, what if they work all night and they're not, and they don't have access to that? So we have to meet the patient where they are. We have to be mindful that not everyone lives on the same schedule and calendar, and we have to take time to say, tell me a little bit about your day. Tell me how your schedule is, and is this realistic for me to write a prescription for you, and is it going to be possible for you to take this medication at these times? Little things that will build such a trust with those patients and providers that it makes a tremendous difference, not only in their understanding, but their desire to want to comply. I find it's a phenomenon that is unlike anything I've ever seen, that patients are so compelled to want to please their providers when they have good relationships. You're welcome. Thank you.
Do you have another? You talked a little bit about health numeracy, but can you talk more about how it fits into health literacy, and also how health numeracy is an issue that we see in health practice areas?
Health numeracy is probably one of the leading issues related to health literacy, along with the culturally and linguistically appropriate services, because you think about it, why do you go to the provider? Well, you're probably sick or you're going for an annual checkup. And most people, at some point in their life are going to be taking medications. And if someone can't calculate and does not understand what a milliliter is versus, a teaspoon versus tablespoon, and how many mils are in that, 5 versus 15, how do we begin to make them take their medication properly, or help them take their medication properly, if they don't even understand how to calculate? And so the newest vital sign that Dr. Weiss in Arizona developed does use that nutrition label. And for folks that are doing research studies related to numeracy, that has been a very useful tool as an assessment. It's not considered a true assessment, but it's really more of a screening tool, if you will, to just give a quick snapshot. So if you have a question with patients, you might want to use that, but I find that to be sometimes even more threatening if you're already suspicious. So you might just want to talk to them, like Dr. Davis in the video clip did with Ms. Tillman, and say, tell me how you take this. Well, do you know what a milliliter is? Do you know what and so that is one way to get to that. But as far as the importance, it is so very important. And there's a huge body of literature out on the internet related to health numeracy, and I encourage you, if you have an interest in that, to seek out that information.
All right, if we've got no more questions, I'll throw it back to you. Any last words that you'd like to say to anybody before we go home?
I really want to leave it with encouraging each of you to look at that Center of Disease Control website and find the state in which you are close to or you live, or one that has begun a health literacy initiative. If your state doesn't have one, then work on getting that done and work with others in your community to establish that. In Alabama, we began work about a year and a half ago to bring together partners across Alabama. I had done a lot of work throughout the years trying to explain health literacy to folks, and they would say, yeah, we're doing all that, we're doing all that. And so I had the opportunity to work with some people to bring together a large number of stakeholders that were leaders in their organization to hear 4 national leading experts that were brought into Alabama to give examples of why this is an important topic, and they were all affiliated with medicine, and it was like a light bulb went off in their heads. So it was very exciting to see the energy that developed from that, and we hope to have our website up and running within the next 6 months, and we will definitely send out a message when that is available. So we don't have ours up yet, but for those that are close to any of the states that do have a health literacy link, reach out to them. Don Rubin in Georgia has done a tremendous amount of work, and I'll miss somebody's name because there's so many wonderful colleagues across the nation that are challenging the status quo and just doing whatever they can to ignite folks for an interest in this area. And reach out to them and either work with them or get them to help you start one in your state. Thank you so much. I appreciate this opportunity.
Thank you, Dr. Dupree, for sharing your knowledge with us, and thank you for watching. You will be able to watch this program on the on-demand section of the website. You can go to alabamapublichealth.gov/ALPHTN. Have a good day.